Here we are. Welcome to London, guys. Welcome to London.
It's a pleasure to be here. Thank you for the wonderful invitation. I'm honored. Allow me to dedicate this talk to my staff at Ascension Saint Thomas Rutherford in Murfreesboro, Tennessee, USA. I'm inspired by their hard work, their dedication, and their super talents. So thank you very much. So it's a pleasure to present a challenging BTK. It's actually not technically challenging, but it's going to generate a lot of discussion about what to do. These are my disclosures. So the presentation is a very young patient, 46-year-old, really bad diabetic, but he had his life together with the treatment, and he's doing well from that standpoint. He had a left below the knee amputation a couple of years prior to seeing me at a different state. And right now he's suffering from a non-healing wound on the right great toe because of a right ingrown toenail removal. His ABI is, of course, almost normal, and obviously this was based on the posterior tibial, and the lesion is on the right great toe tip. And the duplex showed triphasic waveforms above the knee, and then monophasic waveforms in the right ATA and right DPA as expected. So we went in for an antegrade access with a 4 French micropuncture and 018 wire, and we keep the 018 wire for support purposes. And this is the runoff, which I will stop a little bit later. And you can see that the anterior tibial is completely missing, and that's one of the reasons for the false positive ABI and the CLTI presentation despite that. So let's start with a poll. How many of you would go contralateral common femoral artery? How many would go ipsilateral common femoral? How many would go ipsilateral superficial femoral, radial to peripheral, or retrograde dorsalis pedis access from the get-go? So let's start from A. Who would go contralateral up and over? Almost.
Sorry. Do you consider medical therapy with prostanoid alone?
Just medical therapy? So this patient has prostanoid.
Yeah.
Of course, there is some data on that, but you have a 46-year-old who's lost his left leg, who is begging you to revascularize, and not because of the patient, but of course, there's a very good clinical indication. You have Rutherford stage 5, non-healing ulcer after a great toe, right ingrown toenail removal. So I would go as aggressive as I can with percutaneous revascularization, unless there are other opinions with the audience.
Okay, red for the contralateral.
Exactly. Let's raise one flag of yours. Who's going to go for contralateral common femoral artery? Up and over.
Red.
Okay.
Very good.
Great.
Ipsilateral common femoral artery.
Most of the audience.
Vast majority. Ipsilateral SFA. And then please explain why you will go. Okay, why? Why?
So the next few slides are going to show that.
Why you would do?
For the SFA with the front for French sheep, you have a direct access, and you do not have complications. You avoid going in the profunda when you puncture the common femoral artery.
Yeah, I have a few slides on that. So
okay, very good. Who's going to go radial to peripheral? So essentially radial access in order to get the imaging, and peripheral retrograde puncture, which is something you see is very common, especially in OBL, in office-based laboratories in US, because at the end you just compress the two axes, and it's handy to manage in such a setting. And who's going to go for retrograde DPA straight away? Tammy, like a complete retrograde. Okay, so I think we stick with the ipsilateral common femoral artery here in Europe.
So I think the SFA is an option only in obese patients, because sometimes the antegrade puncture of the common femoral artery, it is difficult in very obese patients.
His BMI is 40, absolutely.
Habitus, I think that CFA is better.
Yep.
Okay, yeah, sorry, I lost the patient was obese. Actually, the size also of the artery is pretty big, so it's pretty safe also from the thrombus and spasm point of view. Emiliano?
May I ask you if you did transcutaneous oximetry for this patient in the foot because there is a straight flow to the foot, but in our center we decide after the oximetry the
Absolutely.
level of the lesion.
Yes, this was not done on him, but the clinical presentation was so typical, it was not going to change the management. The patient is suffering from ischemia. It's a false positive, it's a falsely normal ABI. We were going to go for an angiogram regardless, but right on point, if you have this available, that would be absolutely necessary.
I would say also personally, I missed the last part of the angio, I would say, because you see, you reach to the ankle and you don't see the lateral plant, you don't see the pedal loop. I'm sure you will, then you have done it, but also to take a decision on that is pretty difficult. Also, to answer to what Emiliano was saying, the flow looks good, almost down to the ankle level, then it goes down. So that's,
Right.
that's an interesting
Right.
point, isn't it?
And there's absolutely no collateralization. You can tell both the perineal and the posterior tibial are patent. In the traditional way of thinking, you leave this alone. This
Sabine?
patient is going to heal, but there's absolutely no communication between the two anterior and posterior circulation.
Just one short question. Before I would go for any intervention here, I would like to know why a patient with 4 to 6 years is developing such a disease, because this really would change my management.
So he's had diabetes for 15 years. 14 of those 15, his sugar has been at 300, 400. Has not seen a doctor for a very long time. So aggressive type 2 diabetes, angiopathy. So moving on, of course, this audience is very familiar with alternative access. These days, the up and over technique from the contralateral common femoral is a traditional way, but we should consider accesses in every single aspect. Each one of them has pros and cons with regards to bleeding risk and closure potential. But in the below the knee work, it is absolutely essential. What's the advantages of antegrade access? Obviously, avoidance of tortuous iliacs, a tight bifurcation. The force vector that you're using in below the knee is multiplied by 4 to 5 times. Your ability to torque the wires is absolutely magnified. You have better reach, especially if you're going to use atherectomy with 135 to 145 centimeter shafts. You use shorter sheaths, which allow you to use many devices, especially some of the balloon shafts. Also, if you don't have the 200 centimeter, you'll be able to do that from a antegrade access. If you're going to be using a transcollateral approach, it's almost impossible to do it from the contralateral. And the other major aspect that people don't think about is contrast reduction. You have a catheter literally sitting there using sometimes 2 cc's of dye to opacify the tibial. And of course, less operator radiation exposure, especially if you flip the patient.
Can I also interrupt you here? It's important in a case like this, in my opinion, to put a long sheath.
Yes.
Because the long sheath, talking about contrast reduction and this kind of stuff, especially in patients who are, sometimes chronic kidney disease. If you have this sheath, not only will increase the vector, the pushing that you can have through very difficult occlusions, but also will reduce dramatically the amount of contrast and also will increase the quality of the images.
Right.
Do we all agree on that? Who does perform only BTK, let's say, only BTK disease interventions with a short sheath? Raise the flag. Who does with a long sheath? Vast majority. Why, Badri, do you use a short sheath?
I think the reason I use a short sheath is because to prevent in the sheath thrombosis, we got to keep flushing it all the time. And sometimes we had cases where we had an embolization while you're concentrating on the pedal arch and then you forget to flush the sheath. And if you keep flushing the sheath, that's okay. But if not, there's always a risk of thrombosis. And that's why I always go for a short sheath.
Okay, maybe we also forget about the ACT level. This could be another thing.
Yeah.
No.
Can I-
Because that's okay.
Can I just ask, in the meantime, getting back, so for those who are reluctant to use the SFA access, how many of you use an ultrasound-guided access? Raise your flags. And for not users, how many of you don't? And who are not answering, they don't perform cases? From the companies? Okay. So if you want to puncture the SFA, you need to know where is the spot, the proper spot for the puncture, not only for the puncture, but also for your closure device. So ultrasound-guided access is mandatory, in my opinion.
Yeah, just an addition on the previous subject. With the lung sheet, we try to prevent the form of thrombus by using continuous saline drip on the sheet, and that works perfectly in our center. Yeah.
Right. So
That's an
moving on-
interesting point. If you have a dialysis patient and you have a long procedure, you can go to fluid overload. So it's good, but you need also to keep in mind not to flush too much because you're increasing the fluids. If you have the patient on the local anesthesia, I can get the bladder full very, very, very quickly. So it's a good solution, but you have to think twice before doing it, trying to avoid the difficult patients for this thing. That's good. Anyway.
So in BTK work, it's very important to be aware of the ergonomics, your ability to do the procedure with ease. So in the first 10 years of my practice, I used to kind of get up and over, as you see in the first here, not only exposing myself to radiation, but ergonomics, back pain, you're kind of leaning over the patient. So I started flipping the patient in a cranial caudal projection and using the halo device at the head of the patient so that the drape is not covering their head so you can breathe easily. And that has not only increased my ease and ergonomics, but also decreased my contrast use and decreased dramatically my radiation exposure. You're standing almost 6 feet away from the II. So this is so tips on antegrade common femoral artery access. As you see here in this video clip, it is a very shallow angle. You have to account for the skin entry points depending on the patient's pannus and body habitus. Use ultrasound 100% of the time, and this would be absolutely necessary. Now, the disadvantages of common femoral artery access, and I try to convince you that SFA access is a little bit more practical and as safe. Disadvantages, the ergonomics of common femoral artery access. We all have seen the obese patients sticking in a large pannus almost up in the abdomen. The room setup, especially if you don't flip the patients. The skin access site estimation is very hard. The wire in the profunda is sometimes a nightmare, and all of us have done that, and the wire is in the profunda for 20 minutes and you're trying to redirect it. There are some methods to do that. The hand radiation, if you're not using ultrasound, is a problem when you're trying to redirect that. Extravascular ultrasound expertise is definitely needed, including with wire localization, and it requires a learning curve. As you see here, an antegrade access of the common femoral ended up in the profunda, and this is the sheath angiogram. So this technique was published by Dr. Issa and his partners, co-authors, an amazing way to actually get over. If you end up in the profunda, just make a little incision in the side of the sheath and introduce an angled catheter, and that should get you into the superficial femoral artery. But another solution is to actually stick the SFA. There's tons of literature right now on the safety of SFA access, including closure. The advantages is this large pannus, this BMI of 40, like you mentioned. You have direct access to the ostial SFA. You have a little bone below it, the lesser trochanter, against which you can push if you have bleeding issues. Of course, it has a slightly higher risk of hematoma and pseudoaneurysm, but with meticulous anterior wall stick technique and with meticulous closure, you avoid most of that. And this is a... Go ahead.
Just a remark, please. Because we published about the puncture of the SFA, and I think that the puncture should be done in the first 2 centimeters of the SFA to avoid puncture in the sartorius muscle.
Absolutely.
After you can do compression or closure devices and will be safe.
Absolutely. So when I'm scanning for the ultrasound, I always want to look for bone below where I access, and I try to go as high as possible on the SFA. My goal is to get a wire into the SFA and try to be as high as possible. So, and this is a technique, the video that you saw was a closure with a Minx closure device, which has been my go-to for antegrade SFA access with 50-50 contrast and saline in the Minx balloon. So you can pull that Minx under ultrasound and you can see it come back to the access site, which you had fluoro-saved the transition between the needle and the wire. So moving on, this is some of the extensive literature on antegrade SFA access, and I hope I can convince you. You can review these at home. That's another example of an antegrade access, which I'll skip, but The most important thing in access is to use ultrasound, micropuncture, always try to be above a bone, use the smallest sheath possible that would allow you to do the job, and use a full thickness sheath so that it doesn't kink in this location. Manual can be a closure, but you can use also closure devices off-label. You can use purse string sutures externally, use protamine, and obviously you can duplex right after the closure to make sure everything's okay before they go into recovery. So poll 2, sheath size, would you use a 4 French traditional sheath, a 4-5 thin-walled radial sheath, a 5 French traditional sheath, 5-6, or 6 French traditional?
Okay, let's go. Okay, let's raise a flag. 4 French traditional. 4 French, 5 French thin-walled. Thin-walled, okay. Yeah. In an obese patient, you can get some problems with kinking, but it's fine. 5 French traditional. Then it's a good question to ask to any of you. Why,
Okay,
why
I got-
4 French? And why
I
5
got
French?
Claudia here.
Yeah.
5 French. Why?
Well, I think with a 545, normally you just place it in the third portion of the popliteal artery, and normally most of the balloons are 4 French, and it's enough. And in case you need a double wire, also you can place a 014 in a right sange. So I think it's more than enough. You don't need much contrast or serum as well during the
Okay, because, for
perfusion.
example, if not, you
And
need a
it-
7 French if you want to do kissing balloons. So if you go to 5, why not? If you really think that you're going to go forward, then that is put a 7. Use a closure device anyway, and then probably allows you to perform more procedures. Gian Battista, very quick.
I think it is very important in order to make the angiography without removal of the balloon. This is the first point. And the second point is also that you have reduced possibility to have thrombosis inside the sheath in the long procedure, because when you have 4 French device inside 4 French introducer sheath, you have no space for wash.
Okay, could be a reason. Okay, then 5.
So can I just ask you, for those who are using a larger sheath, how many of you, raise your flags, are using a side perfusion?
1, 2,
One.
3. It also, you probably use perfusion.
Which one?
Inside the sheath. Yeah. If you didn't change your mind, please.
I mean, I use always saline infusion, always in all the procedures. I mean, I think this is basic to avoid thrombosis.
Any nitrates inside the infusion?
Sorry?
Any nitrates or just hepsaline?
Saline with 500 milliliters with 1,000 units of heparin.
Okay.
Okay, and then who's going to use a 6 French traditional? 6 French or above? Okay, 1 flag there. Yeah, it's interesting because, I mean, I think that I personally use 7 French. I prefer because then everything is smoothly. In 6 French, you struggle a lot if you want to do a kissing balloon. If you think that you're going to do a kissing ballooning. If not, I think I would avoid personally to use a 6 French, but still, use a closure device of 5.
Can I just ask you, 7 also in women, tiny women?
I mean, of course, if the artery is super small and then I need to perform then a kissing stance and I can even think about doing a retrograde, but in a normal patient like this, he doesn't need kissing stance or kissing ballooning. But if he needs, I always suggest you to position, you start with the 4 French, you see what's going on, and then you start with the 7 French. You can still change it during the procedure, even if with 2 or 14 wires, you put a third or 14 wire and you exchange the sheath over the 3 wires, which work very well. Because if you're stuck with the 2 wires, you're just going to remove everything, put an O35, and put a sheath down. I don't know if you understand what I'm saying. So 3 or 14 wires, I have the same support as a O35 wire. So once you have a guide wire in the anterior tibial, 1 guide wire into the posterior tibial, and you want to perform kissing ballooning without removing the wires, which is always the case probably, then put another O14 wire and put a 7 French, 8 French, whatever you need, over the 3 O14 wires. Okay, something is published by Stanford Group for the aorta, but I think it's very useful also for the BTK.
So obviously, in an antegrade SFA stick, we want to use the smallest sheaths possible, but also we have to think about what we're going to do for that patient. If your goal is a transcollateral a double kissing stent, of course 6 French is your goal. But if you want to do even atherectomy, including orbital atherectomy, you can go with a 4 French sheath. So in this case, we use the 4-5 thin-walled sheath. This has been a blessing from our standpoint because some of the companies, not the Terumo sheaths, but Merit sheaths and Cordis sheaths are braided, even though they're thin-walled, so they're much less prone to kinking. So I would highly recommend that. You get a 4 French sheath and you have 5 French ability to do whatever you want with that. Now, the next poll is, can you move forward, please? Okay, so we had discussed that in terms of short sheath and long sheath. In this case, we used a 23 centimeter sheath, so I'm gonna move on. Poll number 4, crossing strategy. Let's go through these choices.
Yes, I mean, who's gonna use a No35? You don't have a picture of the foot, do you?
Not yet,
later.
but I'll show it to you a little bit later.
Who's gonna use a No35 platform? I'm glad that no one does. 018 platform plus 014 wire. So, for example, 6i. Okay, because for me, this is not a great option because the profile, if you really go for occlusions, is not the best. I would always try to use 014 plus 014. So over the wire balloon plus 014 wire. Okay, dedicated CTO crossing device straight away. Or retrograde access from
the get-go.
Get-go, yeah. Okay, in this case,
right.
which is
So
the get-go? Is it like the lateral plantar?
So obviously there are pros and cons for each one of them, but I went with an 018 microcatheter and an 014 wire, which is option number 2. The reason for that, you could obviously use an over-the-wire balloon, but the microcatheter technology has become so good in terms of your ability to cross subintimal and to torque, to transmit that. The braiding, the coiling within these catheters has been a blessing. Now, if it's a simple stenosis, crossing it with an over-the-wire is totally fine. Plus, the over-the-wire would give you enough support if you inflate it while you're trying to traverse.
Can I say something more?
Yeah.
Not in this case, because this case is a bit like small vessels. But if you use a 4 French, 65 centimeter, then you are able to engage the single tibial vessel, which is super important in case of anterior tibial. Because when you push in the anterior tibial, all the force is applied at the level of the origin. If you put the 65 inside the ostium, if the vessel is big enough, then you can push far more. Yeah, I think it's very nice.
And at this point, obviously, you have the catheter and the wire. What's your choice? Obviously, most of us would like to cross below the knee in an intraluminal fashion, but there are ways to get extraluminal with the catheter and wire techniques. The alternative is if you end up in the subintimal space and you want to get back, you can either keep that wire down there and use another wire and microcatheter to plug that hole so you don't end up in that hole, especially if you looped it. Or you can use a dual lumen catheter. There are a couple of companies that make those where you can keep your wire position, but you don't end up in that subintimal space and you direct the wire back into the true lumen. And
okay,
now there are alternatives.
hold on, Hady.
Yes.
Just get your phones and make a picture of this reference. You will get in this paper 20 ways to cross in a low quest.
That's right.
manner.
I was going to
keep that in mind. This is really useful information.
So these are also examples and from the 20 ways that August was talking about. To increase your support, you have multiple ways of doing that. As many ways to skin the cat. You can either get an over-the-wire balloon and try to push. You can actually get a sheath and cap. You can get your sheath all the way down, especially if you have a 4 French sheath into the anterior tibial, and that multiplies your support by 10 times almost. You can telescope catheters. You can take an 035 catheter inside it. You can take an 018 catheter. That gives you a little bit less support than a sheath, but of course the ability to navigate distally much better. Or you can do the power puncture, which we use in interventional cardiology, by inflating the balloon and stabilizing your microcatheter. Your ability, the microcatheter tendency to pull back is almost nothing. So you can really push hard. You can even honestly be unsafe if you push too hard. And this is the paper that August was referring to. I would highly recommend that you check it. Basically, we went in and now we crossed, now we used ultrasound. As you can imagine, the calcification in these vessels, as you see the shadowing on multiple of these views, are going to actually affect our treatment. So the next poll is, what would you do at this point? Traditional PTA, specialty PTA, DCB, directional atherectomy, orbital atherectomy, laser, or intravascular lithotripsy.
Okay, so let's start with traditional PTA. POBA, normal, for BTK. Specialty PTA, like who's like a high pressure balloon or some sort of
chocolate balloon,
yeah.
angiosculpt, ultrascore.
Which is not very, okay, good, Bruno. DCB, without any data, but yeah, but DCB could be a good option. Directional atherectomy for such a small vessel. No one. Orbital rotational atherectomy. Okay, a few people, it's something that is coming new also in Europe, so we're going to see it later. Probably, I mean,
Lorenzo.
Yes.
So we have the king of evidence here.
Okay, yeah.
Thanos. So what is the evidence on the treatment of BTK? Is there any evidence?
You could argue that yeah, if you've got a fairly extreme lesion, I don't know how you quantify something as extreme, but you could say that you've got decent RCT data to say that a drug-eluting stent, healthy to healthy, is probably a better patency-driven strategy, yeah.
Laser atherectomy, again, not very fancy in Europe, and IVL.
Shockwave.
A shockwave, probably like there's a bit of long lesion, there's no like particular spots. You know, in this case, probably could be difficult. And until we have long balloons for BTK, if we have this kind of long disease vessel, could be difficult. So, what are you going to use?
Before the days when I used before IVUS, I would have gone with a PTA, like some of you have voted for. But the IVUS has changed my algorithm here. Since I saw so much calcium, I went for orbital atherectomy. And this is the mechanism by which the orbital atherectomy system works. The main property of the orbital atherectomy, it has differential cutting, meaning that burr that is spinning at 80,000 RPM all the way up to 120,000 RPM is going to affect the calcium only without affecting the elastic tissue. So it has differential properties. So even if you pass it in an elastic vessel that doesn't have calcium, theoretically you should not cause injury. And that experience has come from the coronary world. And the size of the particulate, as you see, is smaller than the right blood cells. So the need for placing a filter is not really needed in the below the knee space. And obviously, it improves your ability to inflate the balloon at much lower pressures, and it improves the success rate by allowing you to induce less vessel barotrauma while prepping the vessel pretty well.
And I want to say that nominal pressure is so important. Have you ever seen the video from Medtronic where they inflate the balloon? How if you inflate to higher atmospheres than normal, how the balloon torques the vessel and cause dissection? It's a pretty impressive video. They do it in a silicone tube with crosses written on the tube, and you see how the vessel moves really. So if you are able to inflate the balloon, I think in my experience now, at the nominal pressure, this is a game changer for everyone. Long inflation at nominal pressure. Please.
Question. You said that you made a choice for orbital atherectomy based on the IVUS images. Is it also possible to just, on your pre-procedural CTA or even on your X-rays, if you have them,
absolutely.
to make this
if you had a
choice?
CTA, of course, calcium, as you know, is a major problem with opacification of the below the knee vessels, especially if they're diseased. So you're able to see how much calcium there is, but you won't be able to opacify very well. And most of the time in your CT results, the radiologist would say, below the knee, we could not really see very well. Please proceed with the angiogram if clinically indicated. But yes, the amount of calcium, if you have a CT, absolutely.
Yeah. We have the possibility to use in our institution of orbital atherectomy, but we use only when we are not able to advance the balloon inside the artery. This is, I think, a good option, but the main limitation is that you must be sure that total recanalization is intraluminal, because if you have some tract outside of the lumen, the risk of perforation is not negligible.
And this is where
I think that the standard use of this kind of procedure is not recommended. when you have the possibility to advance the balloon?
So obviously, it's find your algorithm right, but you can go straight to orbital atherectomy to minimize the amount of pressure that your balloon angioplasty and minimize the potential for scaffold placing. But yes, if you go in and you can't pass, orbital atherectomy is one of the first elements on your algorithm to cross a non-crossable lesion. It helps you with that. But from here, when we did the IVUS, and we saw that the luminal course of the wire and the amount of calcium, we decided to go with that from the get-go. So as you see here, this is a micro crown. It's 4 French compatible. We went through
Just a question.
Go ahead.
What about the risk of arterial spasm when you use orbital
We
atherectomy?
always-
Because you have a lot of movement of the guide wire and the distalky of the artery.
Yes, so obviously we have extensive experience with that for more than 15 years now. We always use nitroglycerin before and after. Even if you had to use, if your patient is hypotensive, you give nitroglycerin and then literally a few minutes later you reverse it with neosynephrine, but nitro is absolutely necessary. And it's especially when you do an IVUS and you see that the calcium is mostly intimal and medial rather than subadventitial, which is where IVL, intravascular lithotripsy, shines. But when it's more superficial, this is where this device actually shines. And this is the actual device. I'm sure they have, are they available here?
Yes, they are.
So feel free to get familiar with that device. I won't go through the details of that. You have multiple options of the crowns that you use. In this case, we used a micro crown, a small crown, so that allows you to be flexible around the angle of the anterior tibial. But if you really want to go for debulking, you go for the solid crown or for the 2 millimeter crown. And in this case, 3 atmospheres. Look at the balloon expansion at 4 atmospheres in this highly calcified vessel. Complete expansion of a balloon with minimal injury. This was the result after that. And there are multiple areas of haziness in the distal anterior tibial. And I don't know if we have time. Do we have 5 more minutes so we can go? No?
Yeah.
Okay. So the whole purpose of the talk was what would you do for dissections in that segment, not the proximal segment. In this area, IVUS diagnosed a flap, a medial flap, and we decided to go for a TAC, self-expanding stent, which has the advantage of being flexible in this highly mobile, compressible area from multiple muscle compartments. And this actually took care of the problem.
It's a shockwave.
Here you go. So this is the final angiogram of the dorsalis pedis with 1 TAC placed in the flow-limiting dissection. Thank you very much for your attention.
Thank you so much, Hady. So, Baha?
Yes.
Last comment?
A question about the stent. What do you think about the new bioresorbable active stent from Apple?
Yes, so this has a great potential in the proximal, mid and proximal segments. In the distal segments, there's potential for fracture, even for a bioresorbable scaffold. As you can imagine, the first few months, this is actually a stent that has a structure. So the fracture risk, especially at the transition between the AT to the dorsalis pedis, that plantar fascia is extremely compressing and not hostile. I don't suspect that it's going to have good results, but the newest trial of Life BTK showed amazing results in the proximal and mid anterior tibial.